Welcome, everybody, to Trauma Training Tuesday. We're so grateful you're here today um, for an important conversation about postpartum depression. Our special guest star of the day is Shanita Alvarez-Crawley. She is a social worker, right? She has a similar birthday to me. Social workers, it's going to be beautiful. Um, and she's going to be talking to us about this really important topic. And also, we didn't get a chance to tell you, Shanita, but you probably won't be surprised to hear our community is struggling with health disparities around maternal health, similar probably to communities everywhere. But we are really putting a focus on Black maternal health, especially in our community, to change some of the outcomes. And I know that that's something that you're especially interested in and passionate about. So I'm just going to turn it on over to you to share slides and do whatever you'd like to do. And just let us know how we can help you. We'll be keeping our eye on the chat. And thanks so much.
Yeah, thank you for having me. Such a beautiful introduction. Yes, I'm Shanita Alvarez-Crawley. So I wear multiple hats in this arena. If you're in Jersey or any parts of that area, I am a huge maternal health advocate, and I've been like really elbows and knees into the maternal and infant mortality concerns in New Jersey specifically. I like to share this little bit about me. I had at 38, I was pregnant with twins, surprisingly. And so I had all those things that I went through. I gave birth in 2019 to my twin girls. I spent that whole 36 weeks and 3 days on edge about all the things we know about those markers. And as educated as I am, I didn't really understand at that time that I could develop all the things that were actually those extreme morbidity and mortality concerns that we're seeing throughout the US. And then also like just the high riskness of being 38 carrying twins. So I always tell people that I was sitting in my space of privilege in the sense that my provider and I were so close that I could text, call him whenever. And then when I gave birth, go see him every day when I thought that I was going to die, but also not telling family that I thought I was going to die. And that was what I needed to go back to the hospital and I didn't go. So I always felt that if I was not a provider, if I didn't have such access to resources and support and round the clock family members checking on me, I wouldn't be here to talk to you today. So that really shifted me into, I know there's more women like me. And it took a while for me to learn that I was one of those women we were talking about that had experienced that severe morbidity and could have faced mortality. And then I also realized that they may not have the resources, education, or strength that I had to pull myself through it. Also, being a woman of color, how could I go back and tell my family or anyone else that I'm struggling with this? Because everyone's looking at it like, hmm, you should be blessed. You're double blessed. You're double blessed. You're double blessed with twins. And it's like, well, my oldest is 13. I was done having kids. I thought I was done. So, I mean, my youngest was 13 at that time. So that's how I got here. So I know that we're going to really touch on, and I'll try to really incorporate my experience in that. So I was successful in working in New Jersey and putting together a multidisciplinary team where we were able to integrate a birth equity team into 9 OB practices, maternal fetal medicine, and the birthing hospital. And when I first got there, we were really looking at those medical models of the high blood pressure, the preeclampsia. I'm not a medical provider, so I'm using the average words that I understand, right? The hemorrhage and things. And I kept saying, we are missing mental health, especially if we're trying to support women of color, right? Like I spent 36 weeks and 3 days fearful for my life and my two babies' lives, right? When I had preeclampsia, postpartum preeclampsia, and all the swelling and the edema, it didn't go down until I really, really addressed that PTSD of that birth, the day of the birth. That should have been the best day of my life, and it was not. And then the fear that me and my babies were going to die. So if we're not thinking about how we measure that, and no, I wasn't depressed. I was anxious. I was fearful that someone was going to die. And okay, we survived the delivery. are they going to die tonight when I put them down for sleep? So there's these things that when we're thinking about the medical model, we cannot separate mental health. We can't put mental health over here. And we also have to normalize that conversation because I don't think there were many people in my direct support system that I could have really articulated. But yes, I'm experiencing PTSD. And yes, I'm anxious. Yes, I think everyone's going to die. And yes, I'm feeling terrible about saying it. So, that led me to PSI, and then I stand here in front of you guys now as like the director of the Alliance for People of Color. And what we do there is Postpartum Support International is known to train and advocate for perinatal mental health, right? Exactly what we're here to talk about today. And we also recognize that there are many people like me and other Black and Brown communities that really have all these barriers and all these gaps in care, and they struggle with how we get to address our mental health, or if we can even talk about it, or how we name that thing as a thing. So, as a director in the Alliance for People of Color, we design trainings, we design panels, different conversations, and we really create a safe space for providers, practitioners, um, peers, community supports, right? We leverage what the literature tells us about evidence-based programs, right? So I know as a clinician, I'm humble enough to know I've been in social work since 2004, but I also know that it takes a long time before I see a person of color voluntarily walk through my doors and say they need help and they need therapy, right? So we leverage all of these different types of things. Who are they more likely to talk to? And we bring those things together. So I'll talk to you a bit. I'm gonna try to get through it because the PSI slides are the PSI slides, but I feel like we'll probably do better talking about, what's my jam. But I'll try to get with that and share that with you guys, and then I'll leave some space for Q&A.
Absolutely. Everything you said is totally our jam. You're in the right place, and we're so grateful.
Yeah, and I
Thank you.
already feel like I probably have to come back and visit you guys again through to have another conversation or another training.
I love that. Thank you. And Aaliyah is here, who was instrumental in getting some policy change. So we got it at all the levels.
Yeah,
It's
that's amazing.
it's amazing. Thank you.
That's why I said it's
Oh,
another conversation too, because we've got a lot of policy and things that I've worked on in New Jersey, that I would definitely love to come back and share with this group. So, like I said, Postpartum Support International has been around since 1987. It's really our vision is that every family worldwide has access to the information, social support, and professional support to deal with mental health issues related to childbearing. I think it's always been a taboo. You're pregnant, and we are trained to like grow up and have families, and we don't really hold space for really talking about all that goes through it. I always joke about by the time you get back to work, after your leave, mom and dad go back to work, and they're showing everyone wants to see pictures of the baby, and everyone's talking about, oh, the baby's doing this and the baby's doing this. No one ever says, "Oh my God, I'm glad to be back to work," because that was just god awful. The whole experience was god awful. I didn't sleep, but we don't really hold space to talk about that. So I think the work that we do at PSI is so important that we are able to create space to normalize and name that thing. So we provide education, training, professional community, and we incorporate the public. Of course, we build off of lived experience because anyone who's working in any community knows that you really shouldn't be just designing trainings, educations, and talks without hearing from the community first. Like, don't create some fancy little thing and tell me you read some evidence somewhere else and then you're going to come throw this at me and tell me it's going to save my life. You need to know what it looks like. Like, I'm from New Jersey, so I have to understand your state landscape, and what works in Jersey may not work for you. So that's very important that we have lived experience and we honor that. We're very heavy with advocacy and collaboration, and we offer over 50 free support groups that are available virtually that bring together with specific topics, which what I'll share with you later. So, like I shared with you guys, my name is Shanita. I'm the director. I always like to say I'm the mom of five. So I had three children. My youngest was 13, and then I got surprised with twins. So my twin girls are now 7 years old. So we are thriving, surviving, and I'm going gray. I'm way too old for this. I'm not a grandmother because my older kids are over kids because they got these little sisters. So I think it was great, right? I am a mental health provider and advocate in New Jersey and beyond. I do a lot of support with Black maternal and infant health. educator and mentor for future clinicians. So I'm an adjunct professor. I'm a trainer for Child Protective Services in New Jersey. So I train DCF workers on various things, including perinatal mental health. And I also am a field supervisor for clinicians. And I specifically pour into clinicians that are wanting to fill that gap in Black and Brown communities. I'm also a Black and Latina woman. So all of my advocacy, all my conversations are centered on Black and Brown communities and populations. So some of this information may be sensitive. It may also be triggering, especially if people in this room have experienced some sort of trauma or PMH, perinatal mental health mood disorders. So you're free to step away if you need to, come back later. We will do our best to use inclusive language. We do recognize that everyone doesn't identify as mother, right? So you may hear me say from time to time birthing people, and sometimes you may hear me say mother because we're talking about mothers. So it really depends on what that looks like. We think about, we're also acknowledging that research tends to be lacking in using non-binary language, right? So we're also trying to find ways to update that and what that looks like. So we're not offending anyone, but we also try to make sure that we're sticking with what some of that research looks like. So a lot of us talk about postpartum depression, and I feel like that's pretty easy enough. It's a buzzword. Most folks know about it. So I won't spend too much time here, but I like to delineate the difference between what really looks like the criteria for postpartum depression versus baby blues. So we would estimate that about 60 to 80% of birthing people will experience some baby blues in the first 2 weeks of postpartum. If you're seeing them in your office or they're talking to you, they may be tearful. They're definitely exhausted. Their self-esteem is like really struggling because they're like, I cannot do this because no pamphlet that you come home with prepares you for what your little human is about to tell you they want. So they may feel like they're not confident anymore. They don't recognize themselves. I've met with birthing people who are like, did I just 4 weeks ago, was I just the CEO of this great company? Because I feel like an idiot now, right? So how are we navigating that? But we also see that within 2 to 3 weeks, maybe they're starting to move away from that. And they're moving away from what we call the baby blues. If we start to see folks presenting in our spaces that this has been persistent, it's lasted longer than 2 weeks, and it's really impacting their functioning, you really want to pay attention and have that conversation about, is this postpartum depression? So it's very frustrating when people are like, oh, everyone has the baby blues, and mom, dad, family, grandma is like, she's been like this for like 6 weeks. That is postpartum depression. So we want to make sure we're paying attention to that. Um, but in addition to postpartum depression, we also like to point out that there are so many different types of disorders that we find within this population. I remember the first time that I had to hold space with someone who experienced a traumatic birth when I was younger in the field, and I was like, this definitely meets the DSM statistics for like PTSD. It's just very different because this isn't a car accident or a sexual assault. This was birth. So we like to note that there is perinatal anxiety and panic disorder, perinatal obsessive compulsive disorder or OCD, which we'll talk a little bit more about. PTSD does exist, especially when we're talking about morbidity and mortality in communities, because there's a whole bunch of trauma that goes there. Bipolar mood disorders and perinatal postpartum psychosis. So once again, when we're thinking about depression, you're going to see that more depressed mood, excessive crying and sadness. They may have sleep or appetite disturbances. They may feel guilty. They may feel shameful. They may feel worthless. They may feel guilty about feeling depressed about what's supposed to be the best time of their life. Perinatal anxiety and panic disorder tends to also present, right? And I feel like oftentimes clinically, I'll see that folks rely on that EPDS tool and they're like, they have postpartum depression. But as I spend more time with them, I'm really looking at perinatal anxiety, especially in communities of color where they're subjected to systemic systems and different types of oppressive experiences. They may be experiencing greater incidences of those social determinants of health that are really impeding on their ability to feed their children, where they're going to live, how they're going to get to follow-up appointments, what's going on. So we may see more anxiety that's persistent there and more instances of panic. They may be presenting with excessive worry about their health or their baby's health, which I shared in my experience was like, I really thought I was going to die because I had these blood transfusions and the hospital was like, you probably need another one, but they discharged the babies and not me. And nesting wasn't an option at that time. So I'm like, well, who's going to take care of my babies? I'm going home. And their words on the door, on my way out the door when I signed out AMA for that second blood transfusion was, if you feel the way you felt when you fainted trying to go to the bathroom, come back. And I felt that way for about 4 weeks. Right. So there's this excessive worry, like I'm probably going to drop dead. So I couldn't even really sleep. I sat up all the time because I felt like if I went to sleep, I would miss something and die in my sleep. And who was going to take care of my babies? So you may see that, and you may see someone presenting there where they're having difficulty sleeping. They may have racing thoughts where they're continually consumed with that thought of what's going to happen if they go to sleep. And then they may also feel anger or irritability. You may often see episodes of panic attacks that peak within a few minutes. It feels intense. It's a bunch of worry. They often explain it as like it just crashes down. They can't breathe. Some feelings of like feeling doomed and like, what am I going to do? Body shaking, different things like that that I've seen in clinical practice. Like, well, sometimes if nobody. I'm sorry. I can't see it. Somebody. Okay.
We just needed to mute somebody. Sorry about that.
Oh, okay. I didn't know if I needed to stop. I talk fast, so feel free to stop me if you need me to.
You do talk fast, but this is really good information. Thank you.
Okay. Thank you. I'm sorry. I'll slow down a little bit. So perinatal obsessive compulsive disorder, or OCD, is definitely a thing. Definitely something that you'll see sometimes hand in hand with that perinatal anxiety, where there are these reoccurring obsessions where they're experiencing intrusive thoughts. They tend to be persistent, everlasting. They stay there. They're repetitive. They can be upsetting to the individual that's experiencing them. Why do I keep having these thoughts of my baby dying? What is wrong with me? Right? They may also be compelled to engage in various compulsions where they're continually doing this to reduce their fears or obsessions. Hypervigilance in protecting the baby. I often hear that when we're talking about like that fear of SIDS, for instance, right? And they say, I just keep getting up and going and checking to make sure the baby's breathing. This also is present a lot in couples who have had infertility challenges because it's taken so long, maybe, or they thought they couldn't have the baby, and now they're really worried about like this disbelief that the baby's here and I might lose the baby. So I've often seen where they're like, they just stand there all day and watch and make sure the baby's taking their breath. So definitely something that really makes it difficult for them to start being able to kind of take care of themselves or, do different things for themselves when we're thinking about recovery. And then there's this sense of horror, guilt, or shame, especially if they're having these intrusive thoughts that are persistent because they're like they're confused. Like, why am I thinking this about my child? Like, why am I thinking this about my baby? Right? It's important to note that when someone comes in and you're screening them and they tell you that they're having these intrusive thoughts, it does not mean that they want to harm their babies. I do a really cool activity in clinical practice where it's really corny, but I say, for 30 seconds, close your eyes and don't think about you can think about anything you want in the world except for this thing. And it could be something goofy like the color orange. And then after those 30 seconds, I'm like, what did you think about? And they're like, all I thought about was the color orange, because why the hell did you pick the color orange? Right. And we do this kind of to show how the brain can get stuck somewhere. And it doesn't necessarily mean that they want to harm. So it's very important, especially when we're thinking about mandatory reporting. Just because they're telling you that I have this intrusive thought, that alone isn't enough to like report them to CPS, let's say. So we also know that they tend to be disturbing, but we also want to talk a little more and explore that to make sure that they're not delusions or hallucinations, which we'll talk about that shortly. So perinatal post-traumatic stress disorder, PTSD, is exactly what it is. In any other instance that there is something that is traumatic and that you're living with, you're more likely to experience feelings of flashbacks, nightmares of the traumatic event. You may avoid reminders that are associated with that event, and that could be your thoughts, that could be people, that could be places, that could be anxiety or panic if they're forced to go there and they have nowhere else to go, and they may even shut down or detach from others. So I often see this when we're working in this maternal and infant mortality space, where like if I was at maternal fetal medicine for what I thought was a routine appointment, and that's where you told me that my baby's in distress and there's no heart rate, and then I'm raced to the hospital and all these things happen and I lose my child or I lose my life, you may see there that they're avoiding going back to that doctor, going back to that hospital, going back to those places where they learned that bad news or that thing happened to them. And that's very concerning, especially like in New Jersey, we work with a lot of rural communities, right? So that may be the only place that they can go without having to catch like three buses or trains or a 3 hour commute. So they may not get the important follow-up care that they need. So definitely holding space and working with them and treating that the same way you would for anyone else that's experiencing PTSD. Bipolar mood disorders is very important because we know that a lot of times birthing people may already have this diagnosis and have made this like ultimate selfless decision to come off of their medication to improve the outcomes for their infants. So it's very much that we worry about that at that point because they may this may create like issues down the line. So and then often you'll see like they're really, really depressed or irritable. You may also see them presenting with like an elevated mood and more energy than normal, especially for where they're at in their perinatal or postpartum journey. You may see those overconfident, grandiose thoughts, little need for sleep. There may be some impulsiveness and poor judgment that's presenting there. Like I've had clients that or patients that I've worked with where they're like, I haven't slept for like 4 days and I feel great. And they're like chugging Red Bulls in my office. And I'm like, yeah, that's not normal because you just gave birth or whatever. So we're looking through these things. And then maybe sometimes, like, and it's for me, if I'm seeing that, we may come up with some sort of supervision or safety plan that I do just to keep eyes on that. We also know that this is something where at least 50% of birthing people with bipolar disorder are first diagnosed in the postpartum period, which means they've never in their lives known or been told that they had bipolar disorder until they gave birth. And I like to say that a lot of times that's really when I'm having conversations for the first time about diagnoses with folks. When we think about bipolar disorder, we also know that birthing people who have bipolar disorder are at greater risk for developing perinatal or postpartum psychosis, especially when we're talking about that hyperactivity, that decreased need or ability to sleep. We know that sleep is important for the body, for healing, for all the different things. They may start to present with delusions, hallucinations, strange beliefs. They're very agitated, they're very paranoid. They can even go from hyperactivity to severe depression, rapid mood swings. So if we're feeling that there is some sort of postpartum psychosis being developed, it's a medical emergency and they need help immediately. And we advise that you stay with the individual and child to ensure everyone's safety. So how I gave you that example of seeing folks who are 4 days not sleeping and they're chugging Red Bull, and I'm picking up on this bipolar disorder. The reason that I'm putting that safety plan in and maybe trying to develop like, should we do something else? Does something else need to happen? Is because at that point, I'm fearful that they're going to be shifting into this psychosis phase and something could go wrong, right? So those are the conversations, they tend to go hand in hand together. So when we say delusions, if they're coming to you and they're like, I don't know, this damn baby every night their eyes are like glowing red and things are like coming out the walls and talking to me and stuff like that, that's a concern for psychosis and that's an immediate medical emergency. Um, so back to what we were talking about, especially when we're talking about communities of color and or folks that may be presenting as just from different walks of life where they're coming in and they're experiencing these stigmas or these ideals about needing to be strong. Like I laugh all the time because I see like those hoodies and things where it's like strong like a mama. And I'm like, what does that even mean? And then what are we saying to people when we say you got to be strong? Because who defines what strong is? But that is typically something that we're seeing. Like, I need to be strong. I need to do this. And society says that you need to be strong like a mama. So why am I going to ask for a mental health treatment? I just had a baby. That's what I was supposed to do. We really, really see this in communities of color and Black and Latina communities. You may see more of the somatic symptoms that are presenting there. And I want to hold
¿Pero
space.
quiere comer algo? ¿Le hago algo antes de irme?
Is that for me?
All set. Nope.
Okay.
Sorry.
All right. So I want to hold space there because there may be that experience of somatic symptoms. And I like to point out that thought of like when we're looking at folks with high blood pressure and some of the other things that we're seeing in that postpartum period, right? You may also see them often coming in complaining with like backaches, stomach upset, excessive headaches. They're just overly tired, racing heartbeat, shortness of breath. You really want to talk to them about that. And when I suspect that I'm looking at someone with somatic symptoms in my clinical practice, I'll say, now tell me where you feel that in your body. And then we start to explore that. And then I'll engage them in some somatic work and say, tell me what your body's telling you now about that. So that's very interesting that we see that there. Also, partners are important. So I am going to really now shift to binary language in the sense of non-birthing partners can experience PMH conditions, right? So it's not just exclusive the person who gave birth, partners experience it too. We know that postpartum depression affects 1 in 10 dads. Even though their symptoms may show up later and may present very differently from women, um, I often hear people talk about masked male depression, where it may include some sort of withdrawal from the family, irritability, increased substance use, and distancing, where they're like checked out, they're not really there, they're not really helping. I've had some literature where they say like they're working more, they go back to work quicker, those different type of things, and they have like what we call functional depression. They're just avoiding what's going on there. And then it's also about that like what about me type of thing because they feel left out. And when we talk to dads and we've done some panels and some conversations and some research, they're just kind of like, I really don't know where I fit in or what I can do. So I just go to work and stay out the way until they tell me where to be. So we know a lot of the barriers to talking about that is just the gender bias in general. Men are supposed to be strong. They're supposed to protect the family. They're not supposed to be weak. They're not supposed to, have depression or anything like that. Um, so the data and the resources and the literature, of course, is lacking because of that gender bias. And we can also see this in adoptive parents and grandparents as well that could be experiencing perinatal mental health condition. And it really just is a whole family systems type of issue. I could go on and on and on about how it impacts the kids and, the family dynamic. So when we're thinking about risk factors, it's always important to go on with that biopsychosocial. We're really looking at what are some of the pregnancy or birth complications, what are some of the challenges that they experience during that journey. A lot of times, like someone whose infant is in the NICU and they're not able to breastfeed and do all these different things, that could really impact the biological processes. We also know hormonal changes and fertility challenges could increase the risk of developing perinatal mental health. The psychological history of depression or any type of perinatal mental health disorders, that feeling of perfectionism, an unintended or unwanted pregnancy, substance use disorder being present, and just that generational cyclical stress that folks are experiencing. So we also look at contributing factors such as a history of loss, those communities where high stress parenting is an issue. An infant going into the NICU really can upset the perinatal mental health process of the family, and there's a lot of conversations that need to be had about whose fault it is, right? Because they need to blame fault for someone. And then also just those social factors that we think about, specifically when we're thinking of communities that are experiencing financial hardship and stress, healthcare access, systemic racism, and the kind of oppressive systems that they're being subjected to and being forced to navigate right now to even meet their needs and their kids' needs. And then also the fear of bringing kids into the kind of climate that we're bringing them into. History of interpersonal violence. So I have a colleague that does great conversations about the intersectionality of domestic violence and perinatal mental health and the birthing process. So we want to look at all of these. So I always say in practice that biopsychosocial intake is so important in understanding that. And a lot of states have like the pregnancy risk assessment or something like the PRA, where you're able to really get a quick picture of what that looks like to start building that into those conversations. Um, some things that we think are very supportive that can be done. It doesn't have to be in a clinician's office, right? It could be done, like I told you guys when we started, just prioritizing self-care. Mom guilt is a real thing, right? Going and taking a couple minutes for themselves to just feel good about themselves and reconnect to who they are and find their identity is really, really a challenge and very difficult. It's not enough to say, sleep when the baby sleeps. We got to really have those self-care conversations, right? Postpartum planning classes, I find that if we can be preventative and talk about the risk of this happening, and when I work with at-risk moms in New Jersey, we develop a postpartum chart, like who will you ask for help? What are some systems you can get in place now so that you feel a little more empowered and supported in that journey? We really rely on doulas, peers, family, friends, getting the father or the non-birthing parent partner involved early is so important because then they know exactly how they can help and where they need to be. Prioritizing some sort of rest, even if it's not sleep. Nutrition and movement. I love movement, especially when the weather starts to break. If they're seeing me for clinical practice, we do walk and talks so that we can get outside and start to move our body and reconnect with nature and feel the air and see light in the room and assisting with some sort of childcare. So I'm going to go through this really quickly because I'm going to share this with you guys because I do want to hold space to allow you guys some Q&A. It is recommended that at the first prenatal visit, some sort of screening is done, and then at least once in second trimester, and then again in the third trimester. Also, the 6-week postpartum visit is a great opportunity for screening. We also highly support and recommend continued screening within OB and primary care, and also the pediatric visits, because we may find that, like I said, if there's a traumatic birth or you have someone who's experiencing PTSD or some different things, they may never want to see that OB provider again, but they're going to take the baby to the pediatrician. So we want to kind of close those gaps and those loopholes and give ample opportunity to create spaces for families to talk about what they're experiencing mentally. So some evidence-based treatment options, of course, perinatal mental health focus support groups. Those are they could be peer support groups, and they could also be through like a therapeutic kind of model depending on how it looks and if it's going to be peer-led or not. Counseling or therapy on an individual level. Medication, though you may often hear this resistance to wanting to take the medication. New parent groups and classes. And then a lot of times when we talk about inpatient or partial hospitalization, or a perinatal psychology program, there's not a lot that are available everywhere. And I feel like most of the times it's where we're thinking of those more severe cases of like the bipolar or the psychosis because of the high level of risk that happens in that category. But you really hardly see that it would be appropriate to refer for like a partial hospitalization for someone presenting with postpartum depression or anxiety because they don't often want to be separated from their infants. If there is a emergency presenting, then of course we know the 988 and the suicide prevention lifeline. Also, there's the crisis line, and then these are the domestic violence hotlines. I love that, like in 2026, you can text all of these things. So you can text home for crisis to that number, and then text start for domestic violence. So PSI also offers referrals for help seekers. We offer professional development, resources for clinicians, ways to get involved, whether it be volunteer or support. So all of our online support groups all of our services are free, whether it's the helpline, which is the number for support resources. It's available in English and Spanish. Volunteers staff them at least 7 days a week, and then voicemails and texts are always returned. We offer free online support groups. There are facilitators that are trained. There is a perinatal consult line, and other things here. You don't have to have a formal diagnosis to seek support or access resources. So we have an app, and I always recommend supporting downloading the app, and or just the easier way is going to postpartum.net. And then through there's all these different ways that you can get involved and poke around and see what's there for you. I want to say I really relied on that when I first started with that clinic because I wanted to make sure I was getting the perinatal mental health piece right. And PSI was a great resource in training the OB staff and the community and just supporting with that. Also, we have the provider directory, which I use this myself and I really recommend this because this allows providers to register here. It's free of cost. If a help seeker is looking for someone who understands perinatal mental health, because not every practitioner does, they can go through the directory and they can access not only mental health providers, but primary care or obstetric doctors, GYNs, doulas, lactation counselors, physical therapists, peer support, those different things through the directory. And that's the helpline. And I'm going to share this with you guys so you can access all of these things. We also offer the 2-day components of care training. Then there is also the maternal mental health certificate course. Their conference this year is going to be in Los Angeles, June 24th to June 26th. So it's always a great time there. And there's so many great presentations there. And there are various like grief and loss trainings and different things like that that are being offered. When we talk about the perinatal mental health certification and what I shared about the directory, it actually, the PMH-C is professional education and evaluation, and it creates that standardization of training and experience. So it certifies that this provider, this practitioner, this person has met that education, practice, experience criteria to say that they are a certified perinatal mental health provider. And then PSI offers various levels of membership. The Alliance for People of Color, which is my team, really it's all about expanding access and increasing the capacity of perinatal professionals to better support individuals, families, and communities of color around perinatal mood disorders. So we're very proud of our work. We do a lot of lives and talks and lives experience. We have the fellowship program where that's a 10-month intensive research project where they're engaged in a specific topic and it's really focused on research and support for Black and Brown communities. Because when we look at that, we know that that's always what the lack of literature says. Participants' understandings of how to really implement and create evidence-based interventions in communities of color. I'm going to pause there to check in with you guys because everything else is more all the PSI things. Any thoughts or questions or anything in the chat that I can start with?
So much stuff.
That's why I stopped.
Yeah, so much stuff. And we do have a lot of people here that have lived experience, and that's part of what brings them here today. So so much of what you said really clearly resonated with people. Megan noted that she works at a hospital and a lot of patients never come back after fetal demise. So I know I had never even thought of that until you said it, but that of course makes perfect sense. that's going to represent a trauma for you, and that is going to disconnect you from care. Um, wow.
Yeah, because when you think about it, if you're really holding space for the maternal mortality community, the maternal and infant mortality community, what they're going to tell you a lot of times when we talk about preventable deaths, like right before I joined you, I was holding space with someone who had a preventable death. I've been going here and telling you, Amy, something's not right. My body hurts. I'm thirsty. This is happening. I'm 35 weeks, right? But you're telling me this is normal. You're pregnant. What do you expect? And then the person maybe passed that glucose test at 28 weeks with flying colors. So there's no way they can have gestational diabetes. And they're here 35 weeks, 36 weeks, complaining about the same thing, and no one tests them. And then 38 weeks, it's an emergency, and they've lost an infant that should be here, right? It's inconceivable because I'm telling you guys, I carried two babies for 36 weeks and 3 days, but they've been asking for help. So why would they go back there? And on their discharge from that hospital, they're like, we don't know what happened. These things happen. Get over it. You're just a freak of nature, right? That I don't know why that happened. You didn't. And then they open their chart and they see that they had third trimester gestational diabetes. Why are they going to go back? Right? So when you think about that and you think about rural communities, like I said, I'm in New Jersey. So some parts of New Jersey are very dense and very rural. It's going to take 3 hours of public transportation to get across town. They're not going back, but if they made it out with their infant, they're more likely to take their infant to see their provider. So we want to increase the touch points for screening. But when you think about
That,
PTSD, right? That's
yeah.
PTSD. If we're holding space for a rape victim, they may avoid a specific place where that assault happened. They don't like parking garages. They don't like elevators. They don't like creepy houses because this thing happened. So when we really acknowledge that they can have that PTSD, so too can the birthing community.
Wow. That was so much to unpack what you just said there. I was thinking about, we had another training on maternity deserts,
Mm-hmm.
and already the fact that people aren't getting access to the help they need, and and then this just adds another layer of like, you the help you need isn't helping you. Like, you have access, you barely have access, and then when you do, you're invalidated, you're not supported, and it, wow, to just think you're never going back there.
Yeah.
Um,
Yeah.
that that makes sense. The another person, my friend Lynn, commented about intrusive thoughts, and I mean, I know we kind of think about this in child welfare anyways, like it can
Mm-hmm.
be um, reporting, right? Like, people, I feel like sometimes people, sadly, in our people, social workers, can be really quick to be in that cover your own ass mode. They said this, I better do this. And when that is the opposite of what's going to be helpful, and right, how much the anxiety seems really
Mm-hmm.
part of, like, it seems like it's really going to come up, especially for women of color who are already, who are tuned
Over
into.
surveilled. They're already over
Yeah.
surveilled and they're over reported. So what I didn't tell you all is prior to switching out, for 17 years, I worked in CPS. And the reason that I was so close to my provider was because I was his social work consult whenever I came in for my annual exam, or whenever he had someone presenting in his office, he wanted to run it by the expert, me, to see if he should report it or not. And what I find on that EPDS, that last question of, have you had thoughts of harming yourself or someone else? If a person is honest, and Aaliyah, I'm calling you out because I see you nodding your head and you're closest to me, right? If Aaliyah says, I have been having these thoughts, before my doctor knew me, he'd be like, oh, shit,
I'll
I don't
lock
want to
her
be
up.
in the paper. She has thoughts of harming herself. And he'd call me before he started calling me, he'd call the hotline. He'd tell his MA, call the hotline, let them deal with it. And I'd say, just ask the follow-up question. So when I shifted into the healthcare system to build this infrastructure, it was for that reason. So they would page me and I'd come over and I'd say, Aaliyah, what do you mean on question that last question? And she'd be like, I'm tired of the baby crying. I'm tired. I want to go to sleep. I just want to go underwater where I can't hear a baby crying. And I'll say, do you want to stay underwater and die? And she'd say, no, I would never. Why would I do that? Do you want to drown the baby? No, I love my baby. Why would I do that? And I'd say, okay, you're allowed to think that. You're freaked out because now Aaliyah is thinking and her provider is thinking that Aaliyah is going to grab that baby and go underwater and pull both of them down and stay there. Right. And now we have called CPS, had her screened. She's sitting up in PIP where she's already fearful of picking up COVID, let's say. Right. And now she's sitting in PIP waiting to be screened, and who's taking care of her baby, and her whole family's like, Aaliyah, what did you do? You were just supposed to go for your postpartum visit. So it's really getting comfortable with understanding intrusive thoughts can happen, right? Someone saying like every time I go over the bridge, I get this fear that like what if I fly out and the baby flies out the car? Or what if I threw the baby over the bridge right now? Why do people, they could have seen that on the news yesterday. And now they're terrified of bridges and babies.
Aaliyah, jump right in.
Oh no, I was just gonna say thank you first, Shanita, for I would love to stay in contact with you, but for all of this information because I was shaking my head because it's so much that, of course I agree with, but it's just the cultural stigma also associated for Black and Brown families around PPD.
Hmm.
We're taught to kind of tough it out. Hey, all moms had, things difficult, etc. And then when you talk about, of course, health equity and the lack of it, and also just the history and connection and negative connections, unfortunately, with the healthcare system, most Black and Brown individuals are not going to go into an office and state and say, hey, you know, Shanita, I
Hmm.
really am experiencing things that, I don't want to be around my kids or things like
Hmm.
that. And I think it also speaks to the lack of, that village or support system that is no longer there. A lot of communities you had that kind of village where a long time ago, a woman was to have a baby, the community or neighbors would come in,
Hmm.
you would do a food, what do you call it? I'm sorry, I can't think of it right now.
Meal
A
train.
food
Food train, like
train,
a food
or
train. Yep.
yes, or things like that. Now it's a lot of, mothers who have to do all of that alone.
Hmm.
And they think that that's what they experience is just a part of the life of being a
Yeah.
mother.
Yep.
And because they do not get the help, it just carries on. So even hearing you talk about you working for CPS, years ago, I did a lot of the federal policy for victims of crime, but specifically with child abuse. And what
Hmm.
you would see a lot is that a lot of those cases, it was history of a
Hmm.
lot of these moms who were suffering well
Hmm.
before
Yes.
people even identified. And it's like, oh, how does this mom get here? It's
Hmm.
like that mom is not the only one responsible.
Yep.
You know what I mean? It was
Yep.
other people who saw her before then, and didn't dig deeper. So I thank you for it. I think as Amy said, I had personal experience with postpartum myself and perinatal partum as well because I was sick all 9 months in and out the hospital, and that creates its own environment. But even before I had my child, it was just ironic that I played a very integral role in writing the first part of legislation with Congressman Rush around postpartum depression that required, the screenings. But I never even thought
Yeah.
that later on, when I got older, that I would experience it myself. And I
Right.
think we need to have more conversations around it, and for the men too.
Yeah. Oh, yes. So, I mean, like I said, I could come back 3 to 4 times and we could talk about all these different things because we do so much talk about, like, if we were to go that deep, Aaliyah, we would talk about if you believe in somatic things and you believe in
Yes.
intergenerational trauma and experiences, oftentimes that is in our wound, right? We were exposed to
Mhm.
that in our mother's womb. So
Exactly.
we are carrying some of that too, right? Like I didn't, of course, I would love to not be anxious, but I'm feeling anxious. Where did that come from? Right. And it's like, oh, your grandma was, right? And I always do like a fun talk where I say, in me growing up, it was like, oh, Amy ain't been right since she gave birth. She done lost her mind. We
Hmm.
don't know what's going on with Amy. And we don't leave the kids over there with so-and-so because so-and-so, he might touch the kids. And it was like the way that we talked about it, you had these labels, right? Like, oh, she be talking to herself. She got the devil in her. And it's
Hmm.
all these things. So we talked about this and we do a lot of this in our space of like really normalizing that. We weren't even taught to know what does that mean that Amy ain't been right since she had them kids.
Hmm.
And when we talk about, I see somewhere, Natasha, thank you for sharing about your experience with psychosis, right? When we talk
Yes.
about what that looks like and how we call that thing and how we recognize that. And then I talk about CPS and we talked about looking at what that looks like specifically in brown communities, because I feel like only certain people get, I don't want to say it's a badge of honor, but only certain people get to say that I experienced psychosis. But we
Hmm.
often hear about the worst cases and the worst
Exactly.
outcomes when there is a tragedy. You didn't get the luxury of someone identifying that thing that Natasha scored a 26. We need to intervene with her right now because she's at risk. It's like that either or. We don't talk about it till the tragedy happens. And I said, if we were to really go back and look at all those CPS cases through a different lens now and wonder what happened at that time, is there that misdiagnosis of that psychosis? And could the infant's life has been prevented? And mom having to spend the rest of her life in prison knowing that the baby's eyes were glowing and people were telling her to, put that infant underwater. Another talk for another day, Amy. I could come back a million times and hold space with you all.
You really could, and it's so intersectional too, right? Like
Mm.
we have done many sessions on just like trauma and abuse, and recognizing that a lot of trauma stuff comes up when you're giving birth. Like
Hmm.
it's very vulnerable.
Mhm.
Everything leading up to it, it's such a vulnerable time. Um,
It
and
really
people
is.
aren't told about that. Natasha, please jump in. We're so glad to
Yeah,
hear from you.
thank you. Thank you for having me here. In my own experience as well, because I can really only speak on mine and the women that I work with as well. Something else, like on the complete opposite, going through all of this stuff, and I already had another child before I experienced this, hearing all of the things. You're such a great mom. Look at you go. And then to me, I'm just like, if this is what being a great mom is like, I'm not about this, and I don't want to feel this. So it's very important that people like really pay attention. And I heard at the beginning, everybody wants to see pictures of the baby. They're so beautiful. And then a lot of those things, like if you're not aware of like the reality of postpartum, mental health, it could be extremely harmful to people.
Yes, yes. Thank you for that. And that's why it's so important of the work that we do here and having these kind of conversations because we normalize it, right? So having been, like we said, a lot of these diagnoses don't come up until we're in the perinatal journey. And that, you know why? Because I might have been abused, neglected, going through all the things. I think I'm hot stuff because I went to school, I got my degree, I'm doing it my way. I'm not going to be like my mom. I'm not going to be like my dad. I'm not going to be like them people until I have my kids. No one told me how to not be like them people. No one told me that by nature, I am kind of like my mom. I am kind of like my dad. No one told me that the nurture of the 18 years and how my childhood was shaped may erupt when I am exhausted and I don't have a book and I don't have a guide. And the mom that I don't want to be like is the only part of my village left. So that's when I see the vulnerability. That's when I see folks come in. That's when I see folks say, I fly into this rage and I don't know why. And I say, you know what? Let's go back and visit mama. Let's go back mentally and visit mama. Let's go back mentally and visit your trauma. You don't confront it until then. Y'all are a great group. I'm coming to
So glad I
Connecticut.
was muted. I thought I was talking. Thank you. I'm so glad you suggested some screening tools and some screening. And Aaliyah, I'm sure like that's part, I don't think I was screened. I had a kid, 20 years ago. I think it's much newer now. And that is so amazing that we have screening tools and people are screening. And somebody had noted across providers, what a good idea that is. Like, I never thought of that until you said it. Like, you might not go back to this provider. So we can't just have that information with this one person. Yeah, so I'm like 15 things back. People are someone asked, you mentioned PIP. Can you explain what PIP is? And we do
I
have like
answered that.
doulas here and people that
Yeah,
all of that.
I answered PIP. So that's New Jersey. It's a psychiatric intervention.
Ah,
So it's our emergency screening services in New Jersey.
okay. So it'd be
And
emergency mental health in Massachusetts.
yeah, so everyone would have a place where you go if you're in a psychiatric. It's normally the hospital, and they're screening them out. In New Jersey, it's the acronym is PIP, PIP.
Great.
It's the worst place to send a mom who just gave birth, but they do it.
Wow. Heather, do you want to jump in and share your comment here rather than have me read it for you if you're here, if you don't mind? I can, Heather said I had placenta abruption or vesa previa during my first pregnancy, and both my son and I almost died. I did not go back to that hospital or the doctor for my second pregnancy. Just more validation about what you've been saying, Shanita, about, of course, people are going to associate that place with the trauma. And the response, we know, like the response you get when you disclose is so incredibly important. If you're sharing what your struggle is and it's not met with kindness, time, understanding, compassion, that is going to just make things so much worse. It's really going to destroy trust.
Yes.
Natasha, was there anything else? Okay. In my personal experience, I scored 26 on the PHQ-9 at my 6-week follow-up. It's chalked up to pre-existing mental health diagnoses. Right. I can so see that happening. And I appreciate that you talked about how often people's are getting diagnosed because they haven't gotten this attention before. So then the opposite of like, oh, they're already a mental health patient, we don't need to worry about them. Wow. After several months of living in the progression of PPD, I was hospitalized.
Amy, I'm seeing why Ramu has their hand up. Yeah.
Thank you, Wairemu.
Go ahead and jump
Wairemu
in.
had a question in there, a really good one. So please, thank you for being here, Wairemu.
Thank you, Amy. Hi, everyone. So I think my question was just for you to share insight on what's your take on partnerships? And when I mean partnerships is with caregivers and providers where there's already a predisposition of possible postpartum, for example, from mental health providers or from social workers who have seen, a tendency of, either physical or emotional abuse, and then there's a pregnancy. But also, before you answer that, I also wanted to acknowledge the fact that there's also, and I put it in the chat, there's that postpartum depression that comes with like a woman losing herself to a certain level where they get to feel like childbearing is the only thing that now they can achieve, and that's the only thing they're good at. So you end up bearing a child every year because you feel that this is my only form, this is the only way I get validation from my children, and this is the only way I can keep my head above the water. But it's counterproductive because when you have like 5 under 5 or 6 under 6, I mean, it's like a vicious cycle to your mental health as well.
So thank you for those questions. I'm going to answer that first, and then I'm going to go back because those are two different schools of thought. And then we're going to go back to the first question. So for that question, that is not postpartum depression. What has potentially happened there is that there is some other under misdiagnosed need there that has fulfilled for them, right? So I would be interested in knowing what that is, and without having seen them and seen all the things, I can't say that, but I'm gonna say that is not postpartum depression. There's something else going on there. And part of it is psychoeducation too. It may be something else because they're probably not really good at being a mom. But there is some kind of attachment issue or some sort of trauma or something else that's deeply rooted there that those kids are fulfilling. So, but definitely not postpartum depression. It's sad to hear that their worth has been bearing kids and being a mom, but I guarantee you they're not excelling at mothering with all those kids because they haven't had time to be there and be present and be accessed. So if I were a clinician, I would be challenging all of that. If that is how you have built your identity around, I'm now going to challenge that cognitive thought on, are you really doing good at it? Especially if you can't navigate resources, you can't sleep, you guys are piled on top of each other, you can't meet your basic needs. How are you being present for all of those kids? So I would be interested in really getting a clinical picture of that. And I think you asked me about a multidisciplinary team. And I'm going to say absolutely. In this group, I'm sure in every state, you have a domestic violence fatality review committee. You have a child abuse, child fatality review committee. You have all kinds of different committees. I don't know why I want to add an extra syllable onto it. That look at important societal things. And what happens in those MDT teams is I get a medical perspective, a legal, a policy, a lived experience, a doctor, a therapist, and a social worker are kind of the same thing because we're all trained in social work. So, so yeah, you should be doing the same thing in healthcare. It should not be either or. It should be an MDT team, right? So when we built that clinic in the hospital, it was one-stop shop, especially when you're thinking about rural communities or communities without access. You come see maternal fetal medicine. You get to see your provider there or a provider that's there for the day. You can see the social worker and or therapist. You can see your doula, right? And what we do is we get together. So if Amy is the maternal fetal medicine doctor, and I'm right here down the hall, and Amy will come in and say to me and the doula, she needs to go to the hospital if this happens, because we need her to go to hospital right now because we're noticing like decreased fetal movement. She cannot go home. I need you to talk to her to get right to the hospital. This is a medical emergency. I don't think she's getting it. So now we're treating it together in real time. Also, when we're thinking about that PTSD piece, I've had women who have lost their first baby and now they don't want to go to that maternal fetal medicine clinic because of that PTSD, and they are anxious, especially when they're coming up on the anniversary milestone of when they lost their baby. It's 32 weeks for me. I'm freaking out. I don't tell me I can't get any more ultrasounds. And I've had to, my doctor will say, come get your, he's funny. So he'll say, come get your patient and all her anxiety. And I'll say, no, be considerate of my patient's anxiety. Who is it going to hurt to give her another ultrasound today? And he'll say, fine. And he'll do it, right? So yes, it's very important. We should be looking at this, not either or. All of this should be tandem care. We should treat it the same way we treat all the other social issues.
There were so many other questions and things in the chat, but if anybody just wants to jump in, it feels like lots of important stuff came up. I know you kind of hit it too. We had a training about Black fatherhood, and exactly what you said was what they shared. Their experience was like, my wife is not, she's like not in a good space, so I'm just gonna back up and check out. And of course, that is really not what's going to help. I certainly didn't even know that stat about 1 in 10 fathers experiencing. So I feel like just people having this information in advance of needing this information would be so helpful. Aaliyah, feel free to jump in.
Oh, no, I was just going to ask Shanita what her thoughts are on almost requiring an extra day in the hospital. It was one thing that we kind of talked about even when drafting the legislation originally, and what I mean by that is for mothers who already experience traumatic births, meaning I've experienced a traumatic birth, rather than waiting until that mother is at the postpartum checkup, almost treating them like they've already been defined as having postpartum and then sparsing them out. You understand what I mean? At the
I do.
hospital.
I
So
do.
that it's more or less, if I know that that mother has had, a really bad C-section or, a death, then they would already be put into a category of postpartum where they would have an extra day or an extra 2 days at the hospital for somebody to do a deeper dive mental health assessment on that mother, so that they wouldn't have to ask for it. It would be more or less of like, hey, this is required. And then if you don't need it, then, hey, you're free to go. But
See,
at
so I
least,
don't love that, right? And I
okay. It
challenge
was
you
a
with
lot of
this.
people who felt, can you tell?
I don't love required ever.
Okay.
Because it makes people feel away. They're already fearful of something. Some people want to go home. And because they haven't, you don't get any sleep in the hospital. They're in and out
Yeah,
your
that's true.
room. They're checking your blood pressure. They're pricking you. Like my little baby was 5 pounds, 3 ounces. She don't have any more blood in her foot. What do you want
Yes.
from my baby?
Oh,
Right? And it's really sometimes not until we get home. So I love that they screen before they go home, but I also say that it's once they get home in the comfort of their home and they're starting to try to find their groove that we start to see them really feeling it.
Yeah.
I'll also say in many focus
oh,
groups that I did in communities of color, it makes me chuckle. So if you know me and you get to work with me, you know that I'm also seriously unserious sometimes. Like I use humor a lot in practice. And when we're talking about it, I get, Miss Shanita, I lie on those forms because
They,
damn that, they not gonna let me out
mhm,
the hospital if I'm honest.
exactly.
So it doesn't matter if you keep them for 3 days or 10. If they already feel like they distrust the system, they're gonna lie. What I do find really is helpful that I love that we had in our program was home visiting.
Yes.
Right? Because home visiting, and that's why we have those models of home visitation. So if you could push for any legislation, any policy, it would be to
More
afford
doula care.
every birthing person a home visiting nurse within the postpartum period. Because in
Yes.
New Jersey, it's amazing. I supervised a team of nurses where they are just getting out of the hospital. They don't want to tell the hospital, like this hospital here, the social worker there was known to call, like she only felt important when she was being the liaison between the hospital and DCF, Child Protective Services. So she called all the time. So, and the community knows that. Community talks. So nobody was talking to her, telling her anything. And then like 2, 3 weeks later, my home visiting nurses would go, and that's when they're telling everything because they have made it home safely with their infant. So if I had a push policy, I challenge, because what happens is we put require and we put these certain languages.
Mhm.
Most of the people at the top are just really trying to check the box anyway.
Mhm.
So is it impactful? It ends up becoming more counterproductive, in my opinion.
No, thank you for that.
Mhm. Call me anytime. I put my email in the chat. I'd love to hear what policy you're working on. We have
yes. Well,
Mind the
thank
Gap.
you.
We have Mind the Gap in various states. So if you guys are not
Let's mind the
connected,
gap.
the Mind the Gap Coalition. So I'll send you guys that
Mhm.
information where and my colleague Mika, we have state to state different chapters where we really pull together orgs and states and we work on policy together from state to state.
Nice.
So if your state is
Nice.
not involved with Mind the Gap, I'd love to connect you and start having that conversation.
Yeah, that sounds great. And we really do appreciate policy changes we can make too, because we know that that's part of when we look at the outcomes we're having, we know that that's what's responsible at some level. The way that we're doing things, the way we're managing things is leading to these outcomes. And in Massachusetts, at least in Worcester, Massachusetts, we just pretty recently, we give every Black and brown birthing parent at UMass a doula. And so it's really, I feel like it's a pretty great way of thinking about how to make change, right?
Right.
And many doulas are probably here today. And so what can you speak to that at all? Like, what do you feel like Um,
Do they get to pick their own doula?
doubt it. I mean,
I love that.
I bet there's probably some choice they can have, but it probably also depends on it's really an emerging program too. So we would love to hear from you about kind of what would make it next level.
I feel like I'm coming back about 4 more times now.
Yeah,
But from the
exactly.
doula lens, I don't love assigning a doula, right? When we look at why we chose doulas as a model that could work because we said, okay, you see this disparity, and it doesn't even have to be black and brown. Let's say poor communities, right? This happens in poor communities, folks. Like, let's name it. Let's not give it a color. Let's name it. Poor Medicaid clinics, underinsured, no insured. You're seeing higher mortality rates often, right? So when you're looking to what works somewhere, you find evidence that in communities where they have resources and they can access doulas and do beautiful home births and the doctor can come visit them. Why isn't this happening to them? And they're like, oh, well, they have doulas. Doulas work. Doulas are not new. They've been around, right? So what we should not be doing is saying, great, we're going to hurry up and rush to fix a color crisis by throwing them doulas and then just taking 3 people, training them, making them a doula and saying, here you go, poor people, here's your 3 doulas. We should really make the investment in building that as a workforce and creating access and ability, right? I'm a mental health provider.
Yes.
I'm not going to sit here and show off and say I'm a good mental health provider, but I'm a good mental health provider. That doesn't mean that you go take somebody fresh out of school 3 days ago and say, here's a mental health provider. They're not good yet, right? You should be able to pick. You should be able to interview. They have to match with you. When my colleague was looking for a doula, I had a doula that worked for me that I absolutely loved. And you know what my colleague said? Her personality is too big. My husband's going to shrink into the room. She's going to take over the birth experience for my husband. I don't want her. So she got to find other people. It didn't matter that her skill was good. It was important that her personality matched that of her and her family. So the best doula programs are that we train people. So one of my pet peeves when we started doula care in New Jersey in 2020, 2021 was that you're training people for a couple of weeks and you're saying that this is going to be life-saving care, but you're not matching them with people who have been doing it for 20 years with the rich families. So if you're saying that this works for rich families, give these people on the ground rich family training so they can give rich family care to poor people. Otherwise, you're just checking a box and throwing stuff back into the pot, and we'll be like coming back here talking about this again. So I love the idea of offering it. One thing, having worked at the hospital, having been the first hospital in New Jersey to integrate doulas in an MDT team, I also felt that we needed to step out of it. The hospital would have been better supporting the workforce development and creating this roster. Here you go. You're pregnant. Welcome to pregnancy. Here's a provider directory. Find you a doula. You're entitled to it. Help them get trained, help them get able to be reimbursed by registering with the Medicaid or the HMOs, and then putting your advocacy, your dollars, and your initiatives into the training and the support so that they can have a successful workforce.
That's great advice. And we definitely are going to heed that advice and continue to try to support our doula workforce and this, I know that this training will be watched by doulas and some are already here. So it's great that they're going to have this information going into it and be much more attuned to what could be going on. Kelsey, did you notice any questions that I didn't notice or that we didn't get to, or so much? And Shanita, you'll probably, if you didn't already see it, so much stuff in the chat is just people being appreciative and resonant with what you shared. And
yeah, I appreciate sharing space with you guys. And yeah, I appreciate sharing space with you guys and your vulnerability. And I'd love to come back on a different type of training. I do have a lot of experience and I have a great team, and we have a great community. So there are so many, like as I'm hearing, Massachusetts, I have folks who have gone through our fellowship and done research that would love to come and potentially present to this group. I think one of the folks from there is she worked on the fatherhood initiative, the research for 10 months in fellowship. So I'd love to continue conversations, connect back, and find ways to support. And thank you for having me, and thank you for this space. I did put my email in the chat. Would love to see you all come through. How do we talk about Mind the Gap? What are ways that we can get you engaged? Do we need to come down and do an in-person 2-day training? All of those are options, so it's more in depth. So please keep in touch.
Absolutely. Yeah, it sounds like the resources we are going to want to avail ourselves of all the resources. We'll put this recording on the landing page. You said you could share the slides. I'll put them there as well. The screening tools, all of that, so people can have access to that, and we can. Is there anything else before we let Shanita go back to her regular life? Did everybody feel like they wanted to sort of shared what they wanted to share and talked about? Yeah. Thank you, Aaliyah. We were so glad to have you here too with that vital policy experience and expertise.
Yeah.
And Chantel, thank you. Chantel is leading the doula initiative, doing everything she can to really make sure doulas are equipped. We got so much love coming through the chat for you, Shanita.
Thank you. And Chantel,
everything you shared.
Please reach out to me, give me a call. I would love to, we would love to get your doulas trained. I think that especially when we're talking about these communities with limited access, you guys are going to be the front line, right? You guys are going to be the one they invite into your house. The first brown patient I encountered when we started this project in the hospital, she had been there for 2 days and her fists were balled up and she was shaking and she couldn't unball her fist. And I remember walking in, and this is why doulas, lactation, peer, community, partners are so important. I walked in, I said, "Hey girl, what's going on?" Because I'm humorous and I'm very realistic. And she says, "I don't know. I can't unball my fist. I've been like this for days. I want to get home to my baby. They want me to see the social worker. I don't know why, but they want me to see the social worker." So I said, "Well, I'm the social worker." She said, "No, you're not." And I said, "Yes, I am. I'm the social worker. I work here. What's up? Tell me what's going on." She's like, "Are you?" And I said, "Yeah." And she said, "They think maybe I have anxiety. Do Black people get anxiety?" I said, "Yeah, they better, because I spent my whole life working on this. I done had to pay Uncle Sam for this advanced education." And she said, "What about Muslim people?" I said, "I don't think it picks a religion. It just happens." And she cried so deeply. And she was like, "Oh my God, they made me feel like I was crazy." I get emotional when I tell that story. But I said all that to say she had an Islamic community. She had a faith-based community. She had a partner. She had a grandmother. She was never going to see a social worker on her own. And it just so happened to be me. And I tend to do very well with people, right? So it's so important that doulas, communities, peers all understand that this is a thing. There's small things they can do. I am so prideful that if you text me as my friend and said, "Let me know if you need anything," you will not get a text from me. But if you send me a DoorDash with some of my favorite things, I will appreciate it. And that simple conversation helps a community create the community that Aaliyah and other members here were talking about. And I'll leave you guys with that. Reach out to me. I'm available all the time.
Thank you so much. We will be reaching out. We're so grateful. Thanks so much to everybody for being here. We really appreciate your care of this issue. It was wonderful to share space with everybody. Thank you so much. Take good care. We'll see you next month.